Thanks, Miguel. Can everybody hear me okay? Hi, I'm Karen Sanders. I'm the Deputy Chief of the Office of Academic Affiliations in the Veterans Health Administration. I've been in both VA and academics my entire career, and I've been an education administrator for greater than 25 years. So a little bit about the Office of Academic Affiliations for you. I know some of you heard in a subgroup yesterday what I do, but basically we are the office that oversees health professions education for the VA system. We oversee the training of over 40 different kinds of health professionals, and we have paid trainees in over 17 or 18 disciplines right now. Now, VA, normally on the medicine side, we affiliate with academic institutions to provide training. So our GME portfolio is almost universally in conjunction with educational institutions. However, on the other 39 disciplines or so, VA can sponsor training programs and often has their own training programs in many disciplines. We have very big presence in psychology training, for example, podiatry, optometry, pharmacy. So when it comes to accreditation standards, of course, standards concern us. One, because we have VA facilities becoming accredited. But I think the major issue with accreditation, because we do think it sets a bar, at least a floor, for what you get out of your training program. I would say accreditation is the floor. But what we've also seen in our office is that accreditation is sometimes a barrier to experiments and innovation, especially for our newest programs that are interprofessional in nature. So I'm going to actually explain two concrete examples of two kinds of training programs that we have in VA and the intersection with accreditation that's been positive or not. So is there somebody to give me the next slide? Oh, I can give the next slide. There we go. So first of all, I'd like to explain a little bit about our Centers of Excellence in Primary Care Education. This initiative was conceived as a way to increase interest in primary care, especially for medicine trainees, physician residents, but also for other kinds of trainees. And we stood up about 5 sites 5 or 6 years ago, and we've just added 2 more recently. These were very novel VA-based centers that experimented with multidisciplinary teams of trainees managing patient populations. What was unique about these centers is that we tried to have co-directors, one director that was a physician and one director that was a nurse. And then we tried to have co-precepting in the clinical environment. So again, these were based in primary care outpatient clinics, and we wanted there to be a level of equality between disciplines and a fostering of collegiality, across the normal professional silos. But what we found is that some accreditation standards were clearly barriers to accomplishing this. For example, especially on the GME side, I think the nursing side is more flexible with who can be a preceptor. On the medicine side, GME standards say they don't allow non-physician preceptors, and in most settings, except for some very narrow exceptions. And the other thing is the accreditation standards on the GME side actually discourage multiple trainees to be in the learning environment, as it would interfere with the learning of the physician resident. So they saw other trainees as distractors from the care process instead of contributors to the care process, which was a bit perverse, I think, and that standard is still there. So this was an example of how we ran straight into accreditation standards that were actually holding us back and not letting us do what we wanted to do. And I think what the right thing to do is. So I'll go to the next example. Again, very concrete examples of how we are functioning in VA. Yeah, so the second program I wanted to discuss are our Chief Residents in Quality and Safety. This was a program conceived as an alternative to the standard chief resident year in medicine. You may know that in physician residencies, sometimes we allow these trainees to stay on an additional year after their accredited training is over to kind of become junior faculty, if you will, to do some clinical care and supervise lower level trainees, but also to perform a lot of administrative roles and functions like the conference schedule and things like that. So what we were envisioning, and actually this came out of an idea out of one of our sites in Indianapolis, was instead of taking this as an administrative kind of junior faculty year, why don't we actually create a entirely new curriculum for this extra year? And we did. We created a national curriculum in quality and safety. We have national quality and safety experts teaching in it. We have a conference that we bring all these trainees together across the country. As you can see on the slide, there's over 50 sites now, and I think about 60 trainees across the country. And so what does this do at the site that these trainees are in? They actually, having just graduated from their accredited program, they really still have a lot of ties to their colleagues at junior levels. And yet they're also being pulled into the enterprise systems of quality and safety in the facility, in the care delivery system. So they form this incredible liaison role, what I call glue, between the culture and knowledge and firsthand, actually, system knowledge of what the residents see and the quality and safety systems that usually are oblivious to what the residents see, right? I mean, any of you have taken care of patients know there's just this wide chasm between those two worlds. And these folks actually has been very successful in bridging these, the knowledge gaps both ways and forming these liaisons and actually improving quality and safety in the mix. So this was a great idea that came out of no accreditation system, and I probably would have trouble getting it accredited. But again, you can have wonderful educational programs that support quality without any touch to the accreditation system. So with that, I actually have one more slide because I was trying hard to conceptualize this topic, Miguel. And I mean, my organizational schema was the accreditation systems are either education accreditation systems or clinical accreditation systems. And then what I call a kind of dual accreditation evaluation pathway, which is like the clinical learning environment reviews of the ACGME, which I think is a kind of mixture, but the only one I know that kind of tries to bridge education and clinical care. And then the question is, of all these evaluation accreditation systems, what's the impact on the quality of care provided to the patient, outcome being patient care, and what's the impact on the quality of the education, outcome being competency of the practitioner? And so this actually gets quite complicated quite fast, so I'm going to stop there because I can't explain it any further.
Well, maybe we can bounce that to the audience, and perhaps we'll leave that up as a place to start a little bit of a discussion regarding Karen's presentation. It kind of plays nicely with the discussion we had earlier in the day, where I think, at least at my table, we had discussed, maybe the target for accreditation is not necessarily, shouldn't be driven by the program itself or by the learners, but it should be driven by the patients. And here we have an example of how does it impact actual care of the patients versus the quality of the education. Any thoughts?
Dr. Sanders, could you repeat your assertion regarding the tension between the educational accreditation and the clinical accreditation?
Sorry, before we start, I meant to remind everybody, please tell us who you are and your role, and that would be wonderful since we're recording this. Thanks.
Sure. I'm Benjamin Murray, Commission on Collegiate Nursing Education.
So could you repeat your question?
I will repeat my question if you'll repeat your, no. If you could just restate your assertion about the tension between the educational accreditation and the clinical accreditation, and how there may not be that focus on patient outcomes. Is that what I heard you to say?
Well, I think they're two separate domains that actually rarely intersect in my experience, and that might be a problem. Maybe it's a problem. That's an arguable point, right? So I'd actually like to hear the discussion about whether these are parallel, these are like systems that are here, or is there some degree of overlap in the middle, and how do we perceive that overlap to occur? In my experience, Joint Commission accreditation of hospitals and healthcare delivery systems is way over here, not connected to the learning environment or the trainees at all. And the same kind of with education accreditation, it exists way over here. And the only one that seems to bridge that gap a little bit is the CLEAR process at ACGME. So what do you think?
If you'll appreciate this, I'll just take a pass at the moment. How about that?
I'm Mark Merrick from the Commission on Accreditation of Athletic Training Education. And one of the things that we've seen is we have had educational accreditation, but we have not had clinical or facility-based accreditation in our field until fairly recently, and it's still voluntary at this time. It's not a requirement. So prior to the clinical side coming on, a number of our accreditation standards were actually about the facilities at our clinical education sites. And in many cases, those educational standards were a difference in the quality of those clinical sites because of things that they had to do to meet our educational side, which is sort of an unanticipated benefit on the educational side. The other thing that we've seen is that the educational programs and the educational clinical training places tended to attract practitioners who want to teach students. And by doing so, they often have been, in many cases, more progressive thinkers and early adopters of new practices. And that's gone along with their philosophical bent on wanting to help be an educator. So some benefit there on the clinical side.
I'm Elizabeth Hoppy, representing Association of Schools and Colleges of Optometry. Within my professional accrediting body, we have separate standards related to both clinical education and patient care delivery. The patient care delivery standard only covers that patient care that's delivered within the context of the school or college's owned and operated clinical enterprise. A majority of our programs also interact with externship placements, clerkship placements, those types of things. And under those auspices, we're only responsible for accreditation standards related to the clinical education, not to the patient care delivery. So we have a little bit of each. And between the two, I think that the clinical education standards are much stronger than the patient care delivery standards. And I also occasionally will question the ability of the accrediting body and the site visit team to truly have the expertise needed to really evaluate appropriately the patient care being delivered. Of course, we are regulated to some extent by third-party payers, by whoever else might be involved in the regulation of the quality of the patient care delivery. But specific to the accreditation process, it's relatively weak when it comes to the patient care standards.
Malcolm, did you have your hand up?
It seems to me, in thinking about the question that Karen poses, are they here or are they overlapping? I think the answer is both, and it depends on what the outcomes that you're looking at are. If you look at the Kirkpatrick model, I would hypothesize, I'm not sure I've thought this really well through, but I would hypothesize that if you're using reaction or student satisfaction, one of the lower order outcomes, that's one thing, and they might be quite separate. But if you look at the more distal outcomes of collaborative care in practice, for example, as a higher order Kirkpatrick learning outcome, that by definition they have to be together because they're occurring in that clinical care environment. So I think the overlap in the two in the Venn diagram, that potential overlap, is dependent very much on not just the context, but actually the level of outcome of either learning or healthcare delivery outcome that you're looking at. Isn't that right? I mean, I don't know that that's right, but it occurs to me that might be the connecting piece between the two circles. That went over like a lead balloon. So.
Well, and since I'll speak up on this, that seems to make sense, that those things would be
Thank you.
interdependent. But what I'm hearing Karen say is that it doesn't seem like the visits necessarily go that way. They're almost operating completely independent of each other when they come in. Yes.
Hi, I'm Kathy McGuinn from the American Association of the Colleges of Nursing. And I think I've spent half my professional life in practice and half in education. So it is interesting. I was always the one, helping the areas get ready for the Joint Commission. And, we have the Joint Commission come, and the first thing they say is, I'm here to help. In the meantime, we have scripted all the staff to not answer any questions unless they're asked, specifically asked, and trying to script everybody to be on the same page. And then, we have the same issue, I think, with our, accreditation of educational programs. We want to have them be continuous quality improvement experiences too. But in my work at AACN, I've done a lot of work with quality and safety education for nursing, and we did a lot of faculty development related to 6 core competencies, and those were quality improvement, safety, evidence-based practice, informatics, teamwork and collaboration, and patient-centered care. And this is kind of like motherhood and apple pie. I mean, these are all things that every profession needs and every setting needs. And it just seems to me that we do all that work with the faculty, and we get the students all educated about that, and then they go into practice. And it's really not so different. Practice is talking about quality and safety. They're talking about the national patient safety goals and core measures and pay for performance. But I think we have a language problem. But I think if we could get the Joint Commission and our accrediting agencies talking about common competencies or whatever we want to talk about it, maybe, that's how I'm thinking. Maybe it's, just pie in the sky, but just some thoughts.
Yes. Please.
I'm Rosemary Senjum from the Commission for the Accreditation of Birth Centers. So think Joint Commission, only small. Okay, so I'm representing a clinical accrediting body here. I think I'm very much in the minority. But something that is important to us is that students only go to accredited facilities for their residencies and internships and that kind of thing. And I'm astounded at how many university programs particularly we're looking at midwifery, can have students from an accredited school go to an unaccredited birth center to learn, and I don't get how that happens. So to me, some of what needs to occur is more collaboration and recognition at this level of the people in this room. Instead of trying to influence everybody else to cooperate, we need to cooperate and recognize each other's credentials and honor those. And if that takes some vetting and some, poring over each other's documents and, going on each other's site visits, okay, I'm game. But the people who are at the other end of it, who pay all of our salaries, in other words, the people we're accrediting, they don't like it when they need to get accredited by multiple organizations and pay multiple times many thousands of dollars for what feels like the same thing. They don't like it when the credential doesn't mean as much as they want it to in certain arenas because they really want to use it as something they're proud of. And I think a lot of that can be remedied by us collaborating instead of guarding our territory. And I'm saying that as someone who sometimes is guarding my territory. So I just think we can look at how we can compare notes and collaborate.
It's fresh in my mind. Those of you were there in the team assessment session before this plays nicely. These last 2 comments regarding having a language problem and the idea of going on joint site visits. What a wonderful idea. And perhaps you're right. Maybe it's the folks in this room that need to have that discussion. That's really great. Well, in the interest of time, I think we're going to move on and have David give his remarks, and then we'll have another chance for some questions for him as well.